So cornerstones for anesthesia, obviously anesthesia itself. So we have that. So anesthesia essentially just means that the patient has no memory of what happened. And obviously surgery and anything we do surrounding surgery or sedation like colonoscopies, all that kind of stuff can be traumatic for the patient. So this is the way that we essentially improve the patient experience through any procedures or any stressful days that they have. Okay, the next cornerstone that we have after anesthesia is analgesia. So obviously we're doing surgery, there is an incision being made, and really don't want the patient to feel that because that can be particularly pleasant. And then after that we have what's called akinesia. So this is paralysis. And then level 4A is essentially the adjuncts. So any ways we can sweeten the deal with respect to anesthetic and make the outcomes better for the patient. All right, and this could be any emergency medications that we might need if, let's say, things go south for whatever reason, you have an unwell patient. Again, this is the kind of like the X factors for the anesthetic. So, any questions so far with respect to any of this? No? All right, so I guess I'll open up the floor to you guys. So anesthesia. So what, in terms of anesthetics, do you guys know what we use for anesthetics, or any or any medications which induce anesthesia for our patients?
What's the difference between DES and SIBO?
DES and SIBO. Okay, so I mean both are volatile anesthetics. So typically what we do for an anesthetic is we have different ways of inducing an anesthetic. So we have our volatile gases, inhalational anesthetics, or inhalational inductions like for children, versus an intravenous induction, which we could use in pediatric cases, but we also use much more commonly with adults. So with respect to the broad heading of our anesthetic agents, for intravenous ones versus our volatiles, we have SIBO and desflurane under the volatile anesthetics. Really, for all intents and purposes, they do the same thing. So they transition us from an intravenous anesthetic to maintenance phase of our anesthetic. And really it is with respect to the exact properties of the gas, how soluble they are in the patient, and effectively that dictates how quickly the patient is able to breathe off the anesthetic. It's probably outside the scope for what you guys need to know in terms of like why we would use one or another. But let's say desflurane blows off faster in a patient. It's less soluble than sevoflurane, so it stays within the blood, and then basically it will circulate through, and the patient's able to breathe it off faster. So we like it particularly for really obese patients, but it is going out of vogue because of the fact that with the whole issues with respect to climate change in this day and age, it has a much larger carbon footprint than sevoflurane, and stays in the atmosphere for hundreds of years versus like 20 for SIBO. So, so I guess with respect to the anesthetic, so the anesthesia essentially goes through various phases. So for our anesthetic, the initial phase, which you guys all help us with, is the induction phase. We then have maintenance phase, and then essentially we have the exit phase, or the wake up towards the end of the case. So with respect to an anesthetic, the most important phases for anesthesia itself are first when we induce the patient, and then the wake up. That's where you're going to get the most hemodynamic perturbations. That's where we need to be clued in, and then we go on our cell phones through the maintenance phase and basically do whatever else, because most of the time, unless there's some issues going down south of the drape, we're kind of in autopilot at that point in time. But the induction phase is essentially when we give our cocktail of medications, which we'll titrate to the patient in order to effectively have them induced and have them deep enough to tolerate intubation. From there, we'll transition to the maintenance phase, usually using a volatile anesthetic, and we use essentially a marker of depth called MAC, which stands for minimum alveolar concentration. It's basically what we're looking at as a number which says this is the amount of gas that's necessary for the patient not to respond to a surgical cut. And then from there, the wake up itself, which is where we're turning off our medications. Again, we're making sure that the patient is hemodynamically stable through that as they come off, that they're well analgesed, and that ultimately they transition to a fully awake state, such that we can bring in their car recovery. So in terms of our major, I guess, anesthetic medications, propofol, obviously you're all familiar with. That is probably the main one that we use in most patients. Is anyone aware of any other anesthetic, IV anesthetic? Yeah,
that's more
Prestex is
of a- like, that's
Prestex.
not
I would consider an adjunct. You can't, but yes, Prestex can be used in certain for certain anesthetics as kind of like a sole agent. So we'll take that one. Yeah. Any other ones? Ketamine, yeah, very common one.
We're not using phenobarbital anymore.
No, not really. I mean, only in small centers will. Phenobarbital probably not. We'll use barbiturates for induction of during ECTs, but it's very site dependent, and most will use propofol these days. Yeah, the common barbiturate that we now use is like methotrexate. Yeah, so phenobarbital not really.
What's the difference? Why wouldn't you use those over?
Why would
propofol?
we reach for one or the other? Yeah, so with respect to our with respect to the IV agents, again, we're using for induction of anesthesia. So every time we have a patient in front of us, we have a set of goals and we have a set of considerations. We have a patient, which depends on their general medical status and their physical status, like in and around the let's say their medical comorbidities and their physical status before we induce them. So in terms of reaching for one anesthetic or another, it'll be ultimately to meet our goals for inducing the anesthetic such that the patient is not aware during the anesthetic, but also providing them with the most stable induction possible. So with respect to our anesthetic agents, universally they will result in reductions in blood pressure, particularly in our mean arterial pressure, which in certain cases can be detrimental to the patient. Let's say you have a septic patient who's already probably has a low MAP, or a patient with known carotid stenosis where you're like, okay, well, if I drop their pressure too much, they might stroke, or patients with certain valvular heart diseases. So in such cases, it is necessary to again maintain the hemodynamics through the course of the through the course of the induction. So with respect to the medications, the way we make a choice is based off of what the properties of the various meds. So commonly ketamine will be used for patients who are hemodynamically unstable, because it is typically better at inducing a sympathetic response in addition to the normal cardiodepressant properties of the medication. Kind of offsets it usually. There's caveats to that, but that's the reason why ketamine might be used more in a patient who's more hemodynamically stable versus propofol. Really, at the end of the day, it's all titrated to the patient. So, a septic patient who is, coming in with a low MAP, if you crush them with a massive amount of ketamine, you might actually still get a real significant drop in their MAP versus giving let's say 10 milligrams of propofol, just a tiny dose of propofol. So really, it's ultimately titrated to the patient. But what you might find is again ketamine used for or a combination ketamine and propofol used for more unwell patients. Ketamine is very popular in the ER. They love using it for various reasons, but I think that it's mostly physician comfort at this point in time, and a bit of dogma in terms of what it does. But yeah, so that will ultimately be the reason why we have choose one versus another.
I feel like when the patient wake up from ketamine is quite confused and wild.
Yeah, so ketamine has psychotropic properties, so that's probably the main reason why. There are ways of offsetting that. Usually it's a pre-medication with benzodiazepine. So if I induce a patient with ketamine, typically I'll give a little bit of midazolam with that. There's some evidence that offsets it, but usually they shouldn't wake up. Okay, so with respect to ketamine, they shouldn't wake up really agitated unless they're coming off the ketamine by itself. So if you induce a patient with ketamine for induction and maintain them volatile through the course of, let's say, an hour or two surgery, usually I find that actually the wake-up's actually okay, because by that point in time, most of the medication's kind of dispersed through the body, and it's no longer in your main effector compartments. So it shouldn't be that unless you're kind of recurrently redosing the ketamine and you just redose ketamine like legitimately like 10 minutes before extubation. So it shouldn't, but where I see it more is when you're using it as a sole sedative for some procedure in emerge.
Yeah.
And then there's what's called the ketamine hole, which is basically you give ketamine, they're sedated off the ketamine, then they come out and they're like literally like agitated because they're seeing colors and the rest of it. You give them more ketamine in order to kind of sedate them, same thing, and then you basically just slam in ketamine, and you have to have some kind of exit strategy. So ketamine definitely has its drawbacks, and some, the emerge are big fans, but sometimes you need the anesthetic touch, let's say, in order to kind of manage it properly. But that's a different discussion altogether.
Yeah.
So how's Precedex an adjunct?
So how's an adjunct? So Precedex is a bit of a unique medication. I really like it. I like it for kids as a way of kind of smoothing the wake up. Admittedly, it does delay wake up for patients because it's quite a long-acting medication, but it kind of helps with things. Now, Precedex is interesting in the sense that there's two major properties that we like that we use Precedex for. Number one, it doesn't have any respiratory depression, so the patient will breathe through Precedex without you having to worry about whether or not they're going to go apneic on you. The other thing about Precedex is that the way it provides sedation is it is akin to like normal sleep. So the patient will have the same brain waves as if they're sleeping at home in their bed, and it requires brief prompting for them to just open up their eyes and wake up and talk to you, and the minute you stop the stimulation is the minute they'll go back to sleep. I don't feel it's not a reliable sole anesthetic, with certain caveats. Some people will use it now for basically aortic valve replacement, so has like a sole anesthetic, but you're slamming them with a ton of dexmedetomidine in order to do that. I might use it for certain sedation. Again, if I'm worried that the patient might go apneic on me, or they're usually if I'm worried about kind of apnea, that's when I'll use it. I can also use it for like awake intubations. It's a very good agent for that. But as a sole anesthetic, it's just not going to cut it usually, because any stimulation like tapping on patients, speaking to them loudly in their ear will wake them up. So good sedative, not a good sole anesthetic agent.
And it's not as cardiodepressant, is it?
It's a strange one. It can do kind of both. So the way we do give Precedex is we give it a bolus over 10 minutes in order to, basically 1 milligram per kilo per hour over 10 minutes. And then it is essentially, again, given as an infusion. So, sorry, what was the question?
Not as cardiodepressant.
Not as cardiodepressant. So
The
dexmedetomidine you can do either. It can bump up your blood pressure. It can, in theory, drop your blood pressure. It can make you go bradycardic in keeping with that too. Usually we find that it does that if you are giving a loading dose, that initial 10-minute loading dose. And infusions do less of that. Probably not as cardiodepressant or as apt to cause hypertension as some of the other agents. It can still do it though. Like you'll still notice some hemodynamic changes with Precedex, but probably less so than some of the other agents. Cool. All right. I guess the next hallmark of anesthetic is analgesia. So, anyone aware of various ways that we provide analgesia for our patients?
Blocks.
Sorry?
Blocks.
Yeah, blocks. Blocks is a good one. So that's obviously something I really like doing. Believe in, pretty hard.
The intravenous.
Yeah,
the IM
IV,
stuff you do?
oral IV, yeah, block. That's pretty much kind of the main stuff that we use, and then we have our neuraxial techniques as well. So oral medications that we're all familiar with: Tylenol, ketorolac, naproxen, ibuprofen. So anti-inflammatory, adjunctive analgesic medications. We then have our various oral opioid medications, intravenous opioids, and then yes, just basically block them off, and then obviously they'll be completely akinetic over that area as well as blue lung energies. Carly kind of mentioned that maybe some of you guys had questions with respect to blocks and kind of, you know, what to do in those situations. Is there any questions? Just so I'm not like, you know, when I'm about to do a block, I'm like, grab my knee.
I think I told Carly to approach you about that, just because we have had a lot of new people come through, and I think all of us are kind of mostly aware of what you're doing while you're doing a block, but you can't explain it to the point that you would to a lot of the new people, and I don't see any real new people here.
Yeah, so
yeah.
I don't know how commonly, I don't know how commonly blocks are currently being done in our center for the other, with respect to my colleagues.
Not
But
enough.
probably not. Probably
You and
not.
two
But-
others.
We like them in our
Yeah, it's. I think they definitely improve the patient experience overall. They're a great way of either, you know, completely creating analgesia for a patient. They're also a great way of adjunctive analgesia. Let's say for like hernias and stuff, where we can do like a rectus sheath or even like ilioinguinal blocks for our hernia operation. So, I guess with respect to the blocks, you know, I guess the way, there's two ways of thinking about a block from an anesthetic standpoint. There's what we call an analgesic block, there's what we call a surgical block. An analgesic block is usually a plain block, but it can also be a targeted nerve block too. With respect to an analgesic block, the goal is not to create surgical conditions, and by that I mean, it is not my goal to have the patient akinetic, so completely like a dead arm. What it is there to do is there to supplement my anesthetic, so that I might give a general anesthetic, but I don't require any opioids for this patient. The way I induce an analgesic block versus surgical block is I use a lower concentration of local anesthetic, and then I'll target the area that I want to, either a nerve bundle or plain, and then have that medication injected in that area, and then I'll know what my appropriate doses are based off of what volume is typically required to adequately coat the area, and how much is basically the patient's weight to ensure that I'm not creating let's say a setting where they could have anesthetic toxicity. So typically analgesic blocks are lower concentration, 0.25% bupivacaine, 0.2% ropivacaine. I use epinephrine in all facets because it basically increases the longevity of the block. So I'll always give a little bit with respect to the block. So, you know, and then the volume really depends on what I'm blocking up. Usually for, let's say, usually for like an adductor canal block, 20 cc's to 30 cc's, but usually 20 cc's is adequate. For rectus sheath blocks, it'll be like 20 cc's both sides. And if I'm doing something like an ESP block, so one of those ones I'll do in the back for rib fractures, usually about 30 cc's and it's spread. It just depends on the area that you're blocking out. Now the alternative to that is the surgical block. So this is like, you know, someone who would greatly benefit from the surgical block would be, let's say, a patient who's having bicep surgery or like peripheral limb surgery. Because you don't need GA for that. You can basically just target the nerves. You can completely freeze up the area. The patient has a very comfortable experience because you just give them a bit of sedation through the course of the case. They wake up completely comfortably. They go home comfortably. They go to bed comfortably, and then they transition to oral medications, you know, as your instructions, which are essentially when you start feeling that tingling in the fingertips coming back or in your leg, start out the oral medications. So difference, much higher concentration of local anesthetic, with typically a faster acting local anesthetic in addition to the longer acting one. So for me, what I'll do is I'll use 0.5% bupivacaine, 2% lidocaine, 50-50 mix, and then I'll add a little bit of epinephrine in with that. And then in addition to that, we could give adjuncts in this case like Prestex or I use dexamethasone in the block itself to also increase the longevity of the block.
So why the epinephrine? Is it just vasodilating your space that you're?
Yeah, so it's actually opposite. So
Oh.
it vasoconstricts the space.
Or-
So basically, yeah, with respect to, so the vasoconstriction reduces the amount of systemic uptake of the local anesthetic, so it will reduce the potential for toxicity. And it will increase the life of the block because of the fact that basically everything's kind of down, you have less blood flow to the area, so it just keeps everything tight for a little while longer and will just improve the lifespan of the block. So it's something, in my opinion, we should be using for every block that we do because there's really no downside to it.
With toxicity, like how long could that last for, and how long should we be watching for it?
Toxicity. So usually for things like lidocaine, it's pretty quick. For bupivacaine, because it's a longer acting anesthetic, a little bit longer. I can't give you a time frame of how long we should be looking for it, but
But would it be more like intra-procedure and not post-op?
typically admittedly, I've never had to deal with the local anesthetic systemic toxicity. Hopefully it stays that way. I've had friends who have, probably do like an intravascular injection of local anesthetic. So usually it's pretty fast. For them, it was pretty soon after the block, that it was induced. One, they didn't do the block, they just brought the patient over to the OR and they were going like bradycardic and going all these weird rhythms. I would honestly say though that if I've done the block pre-procedure, so pre-procedure, and then we're taking the patient apart, the potential for them to give you trouble with local anesthetic systemic toxicity is probably negligible. Yeah.
What does that look like?
What does it look like? Yeah, so it's a great question. So typically it's tachyarrhythmia. Sorry,
Okay.
it's arrhythmia on the part of the patient. A few of my friends were debating what the most common arrhythmia that you see is. I think it's reported as being ventricular tachycardia as the most common rhythm, but the argument was if you're already in VT, you probably caught it too late. So I think typically the patients will have bradycardia, and then from there they can progress onto tachycardia or tachyarrhythmias like VT, EF. They will generally complain of prodromal symptoms before they start getting that. So it might be like tinnitus or perioral numbness or tingling, a sense of impending doom or just feeling generally unwell. There's also potential for like twitches and pronus because it can be neurotoxic and patients may progress on seizures along with arrhythmias. So that's usually what we see. But you might see rhythm disturbances on the if the patient's not reporting anything else. But usually there are other symptoms. Usually it's a progression towards that first.
And then can you like antidote that?
Yeah. There's actually there's a
Can you Narcan? Will that
Uh,
help?
lipid.
What do you do?
We have
You're
used
so-
lipid.
Treating the
Yeah.
rhythm.
Yeah.
Yeah.
So there is a way. So specific antidote for it is, I think you mentioned it, Jeff.
Lipid, yeah.
Yeah,
Lipid.
intralipid.
Oh.
Yeah. So we use something called intralipid. It looks like propofol.
Yeah.
It's white. It's in a bag. Basically, it's like a lipid emulsifier. It binds the local anesthetic, reduces the amount that's available for essentially creating toxic conditions.
So Myra, is that in, on the cell now? Because it used to be on the cab crash cart.
Oh, it's
No,
not-
in
It's-
in
it's stocked
ultrasound
in the
card.
too,
It's on the anesthetic cart?
No, the
Ultrasound.
ultrasound card for when they're doing blocks. It's right there immediately available.
Oh, yeah. Oh, okay, that's
Yeah.
what it is. Okay, I think there's some.
That's very weird.
No, it's not on the crash cart anymore. They
Should
do
be
the
in
nurses
Omnicell.
take it off.
Well,
Yeah, don't do
It
that.
just
That's
have
too long.
both. Yeah, lipid on in the ultrasound card.
that's
Yeah.
right.
Because we had that issue in Golden.
Oh.
Expired.
We went through all that stuff and we found most of our intralipid was expired. So,
That food project was.
What, oh, the interlipid? That's why it was in the crash cart, because we would check it every month. And now it's off the crash cart.
Probably should be on the crash cart.
Are you sure it's not in the crash cart?
It's not on the crash cart.
Because you think
anymore.
about it, you're dealing with the
You know, if you're doing
tachyarrhythmia.
an arrhythmia,
You
you're
might want
probably
the
gonna
crash cart
have
in there.
the, yeah.
Yeah.
Or is it because they were streamlining it for like the whole hospital?
Yeah,
Did you guys know that that's what it was there for? Like, you knew it was there?
I don't know if the car nurses know that, cause when they took it off, that was when like Deidre had come from Emerge and stuff, so there hasn't been an official streamlining for the whole hospital, that hasn't happened.
I thought that was supposed to have already happened, like a couple
No,
years ago.
no, it didn't happen. I know the educators are looking at
If you
that.
read the documents, they're all supposed to be exactly the same, that's funny.
Mhm.
Yeah, so I think
That makes
you
sense.
can let us
though.
know where are we gonna put the interlipids, so we don't know where it is. I mean, it hasn't happened that much.
I'd probably be nice to have a bag around the crash cart and then just rest it on myself in case you need to redose it.
Mm.
That's just my first comment.
If we put it on like our anesthetic.
How's that infused?
What's that?
How's the interlipid infused?
Oh, I'd have to go through it again. Typically, there's an algorithm, but it's a weight-based initial loading, and then there's an infusion thereafter. I believe it's like, I don't want to, but I personally need to go through it again in terms of dosing, but it's initial. I believe. I'll look at. I can get back to that.
I believe the sheet is attached to that card
Sure.
as well.
I was gonna say, I think there's something attached
It
there.
sounds really bad.
Nobody bags.
I knew this all off the top of my head for my exams, so like I
Right.
could rattle off like that and then
Yeah.
forget it all, but.
Is there any special tubing, anything we have to grab?
No,
It's like a
standard.
ventilator, like
Because it's just
propofol.
like
Yeah.
propofol, so, and because it's in a bag, you don't need.
Yeah, it's bag, spike bag, and then you'll put through an infusion pump because there is a certain infusion rate for it, and as I said, there's initial weight-based bolus. It's 0.2 milligrams per kilo, and then from there you'll move on to infusion, and then basically it's essentially infusion to improve the symptoms, and then pre-dosing part,
It's not
or
your,
double infusion rate.
it wouldn't be your syringe pump, it'd be like a regular.
It probably wouldn't be a syringe pump. It'll be one of those ones that you
It'd be
know,
a Sigma.
Yeah.
Mm.
Call a partners.
Mm.
Any other questions? I guess with respect to
Are you choosing certain analgesics over the other for patients? Because it's usually like what, fentanyl.
So, yeah, I guess yes and no. Like standard. So, there's just, for most cases you'll give them intravenous analgesic during the case. It all really depends on the patient factors and what you feel is beneficial for your patient. So, you can at any point in time in anesthesia, if you can probably pull out some kind of neuraxial or peripheral block technique to either supplement or be your sole analgesic, like radical prostates. You can do thoracic epidural, that's usually what I do for those patients. Because again, it's just more complete manually. Then you take into account the patient's issues, whether or not they have OSA or something along those lines, whereby you might want to reduce the amount of opioid load those patients take. So then you can again try a nerve block. You can try, neuraxial technique. It's very patient dependent. Ultimately, what you choose. But.
Why would you think that maybe, and this is not meant to be like a cut on anybody, but some of the other colleagues are less likely to want to do blocks? Is it just like difference in training, difference in comfort?
Probably, yeah.
Yeah.
You're kind of answering, I think, your own question there.
Yeah.
Yeah, usually differences in
It
training.
just seems like it would be
I
like a
think
gold standard.
it should
patient
be.
care.
I know Justin's asked me to do a talk about it. It's kind of tough when you're the most junior one.
Yeah.
Telling everybody
But they're all
else.
calling you to do it, Brad.
Yeah,
So
no, I
it's-
know. It's yeah.
I'll probably block it and ski for enough.
Block and ski.
I guess the thing is, if you haven't trained like that when as you're going through residency and you're kind of settled into your practice,
Yeah.
there's inertia in terms of changing your practice because even though other ways of doing it are better for the patient, you're like, well, this works for me.
Right.
And anesthesia is kind of siloed in the sense that I have no oversight over what my colleagues do. They do their thing. I kind of do my thing. And we don't have universal practice guidelines here for what we should be doing and nor do we have like an AA, a dedicated block room like some other hospitals have. If we had something like that, it'd be perfect because you basically just have, we do like what we did at like Toronto Western when I was working there. It's like, okay, all these are potentially block candidates, and then you go, okay, so this patient, yep, this will be a block, this will be a block, this will be a block, and then you basically have them all coming through the block area to get done, and then kind of shift it over to the operating room afterwards. I really wish we do that. We don't have the capacity to do that right now. And then yeah, as I said, you know, some of the older staff here, they'll go, well, why would I do this? Because I'm only got a couple more years left of practice, so would I, you know, why would I change things? And then the other thing too is like, you know, I guess the ergonomics of navigating a needle, an ultrasound, difficult for some. Obviously that's just you know, it's practice, but again, like, you know, sometimes it's hard to kind of change practice, even though we see that there's benefits from, you know, my goal would be over the longer term to make it a more common thing here. I think there's so many anesthetics that we can do here with just blocks, and it's, you know, sometimes for lack of better words, it's easy just to do GA on everybody. I knew GA on everybody, and like, you know, without even thinking about it. But you know, I think some more thought should be given as to how we improve things and just make the center that much better for sure. Yeah, mostly as inertia and comfort in practice, and if you're settling in practice, it sometimes can be a bit jarring to be like, there's a new way of doing things. We should be doing it this way now, when you've been doing it like last like 20 years plus, for longer than I've been on the
Yeah,
faces.
I can appreciate that.
Cool. All right, so next heading, Anesthesia. So, you guys aware of any of our AKINE medications? Yeah, pretty much. Yeah, we use like two, and I've seen one more here. Not commonly used, cisatracurium. I guess in theory it's good for patients who are like end-stage renal disease, because of the fact that it is cleared by something called Hoffman elimination. Don't worry about what that is, but it's not renally cleared, so that means it will be eliminated irrespective of liver or renal function. I don't like it. It's kind of a little bit variable in how it works, but some of my staff believe in it back in Toronto again for that specific group of people that honestly rocuronium is partially renally cleared, and I find that if you're using it judiciously, it doesn't really matter. You'll reverse patient with your renal function. But yeah, so main ones that we use: rocuronium, succinylcholine. Succinylcholine, very rapid acting, 45 seconds to produce you know, intubating conditions, and then the offset is about 7 to 9 minutes because of its elimination by pseudocholinesterases, which are basically just enzymes within the blood. And then rocuronium is intermediate acting, so it usually takes about 2 minutes on a 0.6 milligram per kilo intubating dose, 1.2 milligram per kilo being our 0.6 milligram per kilo being our standard induction dose, 1.2 for like rapid onset paralysis and intubation. So for, you know, patients that you are effectively needs non-SI, so that's when we use a higher dose. With respect to medications, succinylcholine reliably is cleared by pseudocholinesterase. We don't reverse succinylcholine. We will give reversal agents for rocuronium. Main reversal agents that we have neostigmine, and we have sugammadex. We work a little bit differently. So neostigmine essentially is an anticholinesterase. So what that does is it increases the amount of acetylcholine at your neuromuscular junction to kind of offset the amount of rocuronium that they have there, because they kind of hang in balance. And then that helps to create the offset. Sugammadex is basically, it's essentially like a ring oligodextrin, so basically like a carbohydrate, and it coats the rocuronium, pulls it out of the neuromuscular junction, and then just binds to it so tightly that it can't bind back. So it's much faster acting and it's more complete than neostigmine. The one thing that we got to look out for with patients with sugammadex these days is the potential for anaphylaxis. So they've kind of noticed that it has been causing anaphylaxis, typically in a subgroup of population that with hairdressers. That's when they go the first time, and I think it's probably because hairsprays and like the dry shampoos they might use actually have those like kind of carbohydrate structures, and they've already been sensitized to the structure of the CDMX beforehand. But yeah, I think it was initially discovered in Japan among hairdressers. Like this stuff that happens.
And how does he get the gas eliminated?
How's it eliminated? I can't remember. I believe it's if I'm not mistaken, it's renally cleared. Yeah, renally cleared. It's very tightly bound. So in theory, for patients with, it's not completely validated for patients with end-stage renal disease, but we still use it anyway without any major issues. Yeah, because it's so tightly bound to the rocuronium, generally once you've got onset of CDMX, the potential for what we call recurization, which is where the rocuronium starts working again, is extremely high.
For surgeries where people are paralyzed, why do sometimes we use the twitch monitor, sometimes not, and like the head, the brainwave monitor, like why is it kind of all over the place whether you use it or not?
The brainwave monitor we use for Tiva anesthetic. So when if I'm doing a volatile anesthetic and I dial my MAC up to 1, anywhere between 0.8 to 1 with a balanced anesthetic, and by that I mean I've given them analgesia, given them adjuncts. They're not. I know my patient's not going to be aware, or I'll see their hemodynamics, and if they're not hypertensive, they're not tachycardic, the risk of awareness is like 0. If I give, and I know I'm reliably giving medication through my through the machine, because I can see that my MAC is 1, so I'm getting that feedback that the patient has medications going in, they're breathing out medication, and it's recirculating through the circuit. With the Tiva anesthetic, it's all through. It's an IV. I have no feedback in terms of what my concentrations are within the patient's compartments, but I'm assuming that in the absence of using that the maximum longer, I'm assuming that I am giving a good anesthetic again by seeing that there's no issues with hemodynamics. And I've had staff through residency who are like, you don't need that. You can just do it all off whether or not the patient's tachycardic and hypertensive. But now we have a better way of doing it. So for Tiva, we'll use that. The only other time I might use that is, let's say I have, admittedly this would be very rare here, but in a trauma center, I have a gunshot, victim or some other major trauma. They're, bleeding out, and I'm giving like negligible anesthetic. Like I might be giving like a milligram of midazolam, every hour in order to kind of resize patients. And I've done it that way for very unwell patients. Well, I might put it on at that point in time to go, is this patient aware through all of this, through this laparotomy that they're having? The answer is probably no, because of the fact that their brain's just not getting adequate like circulating volume. But you might do it like that at this point. Typically, so again, here Tiva anesthetic, it'll be put on for Tiva anesthetic. With respect to the twitch monitor, really the answer is anytime a patient has a neuromuscular blocker administered, you should have a twitch monitor. That's pretty much a CAS guideline. Some of us don't do that because we're a little bit lazy more than anything else, myself included. And usually, if it's going to be a short anesthetic, I don't like a twitch monitor. And like I'm not redosing the rocket. I'm like for an appendectomy. I'm like, for me, I'll kind of go, why do I really need this twitch monitor if I've given a judicious dose of rocuronium that's reversible? I probably wouldn't do it. If it's an all-day case, like big like laparotomy or something where I need to continuously redose rocuronium, I would put it on then and just kind of see where we're at. See if we need to redose rocuronium if the surgeons are asking for it, and then see whether or not my patient's adequately reversed. But the answer is, it is actually dictated by the Anesthesia Society that we should be doing it in pretty much all cases of muscular blockade. Just guess that brings us